Welcome back, everyone. My pleasure to introduce Dr. Kevin Ard. Dr. Ard is an assistant professor of medicine at Harvard Medical School and co-clinical director of the Division of Infectious Diseases and director of the Sexual Health Clinic at the Massachusetts General Hospital. And Dr. Ard is going to be talking to us about STI prevention and treatment. Dr. Ard, want to give you a very warm welcome to our primary care medicine CME course. Thank you for joining us.
Thank you. It's great to be here, and thank you all for joining. As Dr. Pell said, we'll be talking about STI prevention and treatment, and I do have some polling questions for you in this talk, so please do respond to those polls for our case-based questions as we move along. Here are my disclosures. In this session, we hope to describe current best practices in the diagnosis and management of common sexually transmitted infections, or STIs. We'll also summarize approaches to more complex scenarios, like recurrent or refractory infections, including the evaluation of suspected antimicrobial resistant Mycoplasma genitalium, which is an increasing problem, and also Neisseria gonorrhea. And then we'll talk about identifying patients who may benefit from doxycycline post-exposure prophylaxis, or doxy-PEP for STIs, and describe an approach to shared decision-making with patients around that intervention. And we'll do this through cases. So our first case is a 22-year-old woman who presents for a routine annual visit. She has no symptoms. And so my first polling question for you is, for which, if any, STIs should she be screened? And there should be a poll that will pop up that you can answer. Would the answer be HIV, syphilis, chlamydia, and gonorrhea? Would it be HIV, trichomonas, chlamydia, and gonorrhea? Would it be Mycoplasma genitalium, HIV, and gonorrhea? Or do you need more information to determine the best answer? So I'll give you a few seconds to select your answer. Looks like we have about 13 people who voted so far. We'll wait for a few more votes to come in. Okay. So I'll share the results. It looks like 59% of you chose D, which is the answer that I would choose as well. And then smaller proportions chose A and B. I'm glad that no one chose C because we don't recommend screening for Mycoplasma genitalium. Great. So let's talk a bit about STI screening. And my approach to this involves 3 steps. The first is to elicit a sexual history. I think it's difficult to screen appropriately without that step. It's also important to understand what anatomy your patient has. Do they have a cervix? Do they have a penis? And so forth. And then third, to assess for factors that are either associated with an increased likelihood for STIs or their sequelae. And I think that there are really 4 categories you would think of here. For cisgender women and other people who with a vagina and cervix who are younger than 25, screening for gonorrhea and chlamydia is recommended annually. And now in much of the US, screening for syphilis is recommended at least once. We'll talk about that more in a moment. And then screening for trichomonas is recommended if the person has risk factors, such as multiple sex partners, or if they live in a high prevalence community. If your patient is pregnant, then gonorrhea and chlamydia screening is recommended at the first prenatal visit, and then again in the 3rd trimester if risk factors are present. Syphilis screening is very important given the rise in congenital syphilis that we've seen in this country, and screening for that condition is recommended at the first prenatal visit, and then again at delivery if there are risk factors. I should also mention that you may have state or local guidance or even laws that dictate how syphilis screening should be performed in pregnancy, and I would follow those depending on where you live and practice. And then trichomonas screening is recommended for pregnant people who are living with HIV. If your patient has HIV, then screening for gonorrhea, chlamydia, syphilis, and then trichomonas for those with the cervix is recommended upon entry into care. And then you would screen subsequently based on the sexual history. If the person is taking HIV pre-exposure prophylaxis or PrEP, then depending on several factors, screening would be recommended fairly frequently. with gonorrhea and chlamydia and syphilis screening performed every 3 to 4 months for MSM and transgender women, and then every 6 months for others. And I think if your patient fits into none of those categories, then I would offer baseline gonorrhea, chlamydia, and syphilis screening and then screen subsequently based on the sexual history. Now, in recent years, there has been a new suggestion for to expand syphilis screening in the U.S., with the CDC indicating that we should screen all sexually active people ages 15 to 44 years for syphilis in high prevalence settings. And this is because historically we've focused predominantly on individual risk factors, but now for many people with syphilis, their most significant risk factor is actually living in a community that has a high rate of syphilis. And so in 2023, the CDC said that we should screen for syphilis among sexually active people um, between these age cutoffs of 15 and 44 when the local rate of early syphilis exceeds 4.6 per 100,000 among women. And that threshold is reached in all of the teal shaded counties in that map on the right. And this corresponds to more than 70% of the US population. In the most recent estimate I saw, it was 75%. So, what are the best specimen types for STI screening? Well, for chlamydia and gonorrhea, we're using nucleic acid amplification tests. These can be sent from the throat, the rectum, the vagina, or the endocervix. Um, these can be self-collected by patients, with the exception of the endocervical swab, with no decrement in accuracy. For people who have a penis, a urine test is the best test. It is just as sensitive as a urethral swab. There's no need to do a urethral swab if the patient is able to urinate. And the urine specimen that we're looking for here is a first catch urine, meaning the first urine that exits the body in that episode of urination. For syphilis screening, we're doing a serology, and depending on the laboratory, that may begin with a non-treponemal test like an RPR, or with a treponemal test like a treponemal antibody. And then if that's positive, it's reflexed to confirmation with the opposite type of test. So if the RPR is reactive, the next PET test performed would be a treponemal antibody. If the treponemal antibody is reactive, the next test performed would be an RPR. And it's very important that the laboratory follows that algorithm so you know if this is a true positive result or if the initial test was a false positive. For trichomonas, the preferred test is also a nucleic acid amplification test from the vagina or the endocervix. A urine sample is also possible. And then, of course, for HIV, an antibody antigen assay is preferred for screening because this catches many recent infections in addition to chronic established infections. There is kind of a newer concern that if someone has had recent antiretroviral exposure, such as through post-exposure prophylaxis or pre-exposure prophylaxis, then in some scenarios you may want to send an HIV RNA assay as well, and I can say more about that if people have questions later. I also want to emphasize that all adults should be screened for hepatitis B and C. These are not classically STIs, although they can be transmitted by sex, and so it's important to remember that as well. Now, one question that may come up for our patient, our 22-year-old woman, is whether she should be offered extragenital testing for gonorrhea and chlamydia. And in the most recent iteration of CDC's guidelines, they say that women can be screened based on their sexual behavior through shared decision making. And this is also recommended for men who have sex with men. In addition, it's recommended for transgender and gender diverse people based on their anatomy and their sexual behavior. And so our approach is to offer extragenital testing, and by that I mean pharyngeal and rectal testing, routinely for sexually active people who have an increased likelihood for STIs, since sexual history-based approaches may be suboptimal. I would note that it is not recommended to test the pharynx for chlamydia because infection with chlamydia at that site is quite uncommon and is of uncertain clinical significance. So our next patient is a 37-year-old man who presents with dysuria and urethral discharge. He has a NAT for gonorrhea and chlamydia from the urine that is negative, and then he received doxycycline for 7 days for non-gonococcal urethritis, not otherwise specified. His symptoms improve on that treatment, but they worsen 5 days after stopping the antibiotic. And then he has a urine nat for Mycoplasma genitalium, which is positive. He receives what is recommended as the standard treatment in the US, and that is doxycycline for 7 days, followed by moxifloxacin for 7 days. His symptoms again improve. They never fully resolve, but then they worsen again after he stops the antibiotics. And so, 3 weeks after he's completed this treatment, he has another urine nat for Mycoplasma genitalium, and this is again positive. So, here we have another polling question. What is the next best step in management? And we'll go ahead and launch that poll. Is it to treat again with doxycycline followed by moxifloxacin, to treat with doxycycline followed by azithromycin, to obtain macrolide testing to guide treatment, to treat with minocycline for 2 weeks, or to treat with minocycline and metronidazole for 2 weeks, to treat with tinidazole for 7 days, or observe off of antibiotics. And it looks like we only have 4 choices, and I gave you more options there, so you can only vote on the top 4. Please go ahead and enter your responses. Great, so we have a spectrum of responses here. I'll give you a few more seconds to answer. And you should be able to see the results. The largest proportion chose C, to obtain macrolide resistance testing to guide treatment. And then a smattering of you chose other options, the least popular being A, to simply give the same treatment again. So, I think that C, D, or E would all be reasonable approaches to this patient. We do now have macrolide resistance testing in the US, but as I'll share in a moment, macrolide resistance is very common. And so it's actually unlikely that this patient may have a macrolide susceptible organism. And so while you can do that, it might lead to delays in treatment. And then both options D and E might be successful. Taking a step back for a moment, though, I want to highlight that Mycoplasma genitalium is really increasingly problematic. We know that urogenital infection is present in 17% of sexual health clinic attendees, including just under a third of men with urethritis. And even if someone is diagnosed with chlamydia or gonorrhea, it doesn't mean that they don't also have this organism. Co-infection occurs in around 1/4 of people. As I mentioned a moment ago, macrolide resistance is present in up to 71% of infections in the US, and this is really geographically distributed, with high rates of resistance, for example, in North Carolina, and lower rates of resistance in some other places. But chances are in many locations that these infections will not be susceptible to macrolides. We do, though, now have the ability to obtain this test commercially. And if you can't use a macrolide, the other first-line option is to give doxycycline followed by moxifloxacin, but fluoroquinolone resistance is present in an increasing number of infections worldwide, and we're also now seeing dual-class resistance, where M. genitalium is resistant to both azithromycin and to moxifloxacin. That's still uncommon, but as you can see in this figure on the right side, it has been increasing in prevalence around the world. So what would be options for management of M. genitalium treatment failure? Well, we don't really have excellent data about this, but I'm showing you options here which have some, and in most cases, case series level data. One option is a drug called pristinamycin for 10 days with or without doxycycline, and that can cure up to 100% of people. However, pristinamycin is not available in the US, and so that's really not an option for many of our patients. Regimens including minocycline have shown a fair level of success in studies of treatment-resistant M. genitalium, with up to 71% success rate with minocycline alone, or 81% with minocycline plus metronidazole. It may seem odd that metronidazole is included here, but there is in vitro data showing that the nitroimidazoles like metronidazole and tinidazole are active against M. genitalium. And then there's one successful case report of using tinidazole. So in this scenario, I would likely use one of the minocycline-based regimens, probably including metronidazole if the patient could tolerate that. Our next patient is a 25-year-old woman who presents in follow-up after treatment for pharyngeal gonorrhea. She was originally tested after a sex partner tested and was diagnosed with gonorrhea. 3 weeks ago, she received the standard treatment, ceftriaxone 500 milligrams intramuscularly once. And then she had a test of cure, as is recommended for pharyngeal gonorrhea in the US, and that was positive for the organism again. So, treated for pharyngeal gonorrhea, but on a test of cure performed 2 to 4 weeks later, she was still positive. So, how would you treat her? And we can go ahead and launch the poll for this question. Would you give her the same treatment again, ceftriaxone 500 milligrams IM once? Would you give her a higher dose of ceftriaxone? Would you give her gentamicin plus azithromycin? Would you recommend gargling with Listerine, which has been an approach that's been evaluated? Or would you do something else? So let's launch that poll and see what you select. We'll give you a few more seconds to answer. Okay. So 45% of you chose C, gentamicin with azithromycin. And then it looks like the next most popular options were a higher dose of ceftriaxone or something else, or even gargling with Listerine. Okay. Well, in this scenario, I would probably do A. And the reason is that most apparent gonorrhea treatment failures are not due to resistance, but they're actually reinfections, and you can treat with the same regimen all over again. We can talk about a few of these other options, but one thing I would say about C is that gentamicin likely has no activity against gonorrhea in the pharynx. And in the body of evidence we have about non-ceftriaxone regimens for pharyngeal gonorrhea, azithromycin alone at a high dose, 2 grams once, may cure the infection, but the gentamicin probably adds nothing to that success rate. So pharyngeal gonorrhea really continues to pose some clinical and some public health challenges. Nearly all infections, more than 90%, are asymptomatic, but there are data showing that they may drive transmission, and they may also drive antimicrobial resistance because of the presence of commensal bacterial species in the throat. In addition, it's very difficult to culture these infections. Only about 28% of pharyngeal infections that are positive on NAT are culture positive, and that limits our ability to do susceptibility testing to understand which antibiotics might be preferable. Now, these infections can self-resolve, although it may take a long time. This Kaplan-Meier curve on the right is showing you that the median duration of pharyngeal gonorrhea with no intervention is 16 weeks. So people do clear these infections on their own, but and after an average of 4 months. And then after treatment, the median time to clearance by NAT is 3 days, with more than 95% clearing by 12 days. And so that is why when a test of cure is performed, it is done at 2 weeks or a little bit later. And the test of cure, as I mentioned, is recommended for gonorrhea at this site because the success rate, even with ceftriaxone, is lower than for other anatomic sites. That being said, we have some new data from CDC, and the citation is listed there at the bottom of this slide from this year, showing that test of cure is pretty low yield. It is low yield at identifying true treatment failure or ceftriaxone resistance, and most positive tests of cure are reinfections. And for that reason, unless you have specific factors that make you very worried about ceftriaxone non-susceptible gonorrhea, you can treat the patients with the same regimen they received initially. When might you use 1 gram of ceftriaxone? Well, it's recommended if the person weighs at least 150 kilograms. Now, you may know that two novel agents have been under FDA review for the treatment of gonorrhea, but they're actually unlikely to be useful for pharyngeal gonorrhea. And these are gepotidacin and zoliflodacin. You can see that these are highly successful at curing urogenital gonorrhea with more than 90% success and similar results to ceftriaxone. But when you look at pharyngeal gonorrhea, the success rates are lower, 78% for gepotidacin, and then 50 to 82% for zoliflodacin, depending on the dose. This kind of anatomic site of infection continues to be one that really stymies most of our treatments, including actually ceftriaxone. If you do have a case of suspected treatment failure for gonorrhea, then you can reach out to your local Department of Public Health and/or CDC, and there is a way you can request a consultation with experts at CDC around treatment of apparent or the possible scenario of gonorrhea treatment resistance. I'd also note that drug-resistant gonorrhea has been identified in the US. Massachusetts has 4 cases. They most recently reported the most recent cases in September 2025, and these have been ceftriaxone non-susceptible strains. Interestingly, in these cases, however, the patients were cured by standard therapy with ceftriaxone because that relatively high dose that we give was able to overcome the reduced susceptibility in the organisms. Our next patient is a 32-year-old woman who receives a diagnosis of secondary syphilis based on a typical rash and a newly positive treponemal antibody, which is then reflexed to an RPR, and her titer is 1 to 64. She's not pregnant, and she has no ocular, otic, or neurologic signs or symptoms. She has a history of a non-specific rash to penicillin 20 years ago, and she's had severe nausea with doxycycline. And there's a photo of her rash there on the right-hand side of the slide. This is the rash, I should say, with her syphilis diagnosis, not with the penicillin 20 years ago. So what is the next best step in management for her? Would you prescribe doxycycline for 14 days with an anti-nausea medicine? Would you administer ceftriaxone 1 gram daily for 10 days? Would you provide an amoxicillin oral challenge and treat with benzathine penicillin if the challenge is successful? Would you prescribe cefixime for 10 days or linezolid for 5 days, or would you do something else? So please go ahead and list or vote for your favorite response. I'll give you a few more seconds to vote. Okay. So 64% of you chose C. I love that. I think that's an excellent answer. And then the next most popular was B. Very good. What this case is really getting at is the setting of drug allergy and also whether there are non-penicillin alternatives for treatment of syphilis. I think actually that A, B, or C would all be reasonable options for this patient. Doxycycline is our most evidence-based alternative to penicillin for syphilis treatment. And this shows you the results from a meta-analysis in which doxycycline was non-inferior to penicillin. Ceftriaxone is also an evidence-based alternative, but it would be difficult in many clinical practices for someone to come every day for 10 days to receive parenteral ceftriaxone either via intramuscular injection or via IV, but that is also an option. We do, however, need other alternatives, and one that is currently being studied is the oral drug cefixime. These are preliminary results from a randomized trial comparing cefixime to benzathine penicillin for early syphilis. A small number of people also received doxycycline as part of this study because of shortages of penicillin. But you can see that in this preliminary analysis that cefixime for 10 days performed similarly to benzathine penicillin. There are other alternatives that are under investigation. One is linezolid, which is an interesting choice, but this is included because it is on the WHO essential medicines list. However, there was a study of linezolid for 5 days for early syphilis in which that drug was inferior to benzathine penicillin. I would note, though, that this was only a 5-day treatment, and it was linezolid dosed once daily. When we give benzathine penicillin, people have levels of the drug in their system for about 10 days. And so there is a study of twice daily linezolid for 10 days that is currently underway, and we don't yet have the results of that study. There's also interest in dalbavancin for syphilis, which is a very interesting choice. This is active against Treponema pallidum, the causative agent of syphilis in vitro, and it's also attractive because it's a long-acting single-dose treatment. But neither of these, linezolid or dalbavancin, are ready for prime time. I think in terms of alternatives, we're mostly looking at doxycycline, ceftriaxone, and possibly in the near future, cefixime. But as many of you chose in this case, I want to highlight that perhaps no alternative to penicillin is needed for this patient. And I think that there is increasing comfort with oral amoxicillin or penicillin challenges in people in the outpatient setting, even if they meet certain criteria. One example of this is a recent randomized trial of outpatients who were coming to a sexual health clinic and reported penicillin allergy. Their allergy was then classified as low or high risk. Low risk meant that they had an unknown reaction more than 10 years ago, that it was simply a family history of drug allergy and not a known personal history. Low risk could also mean that their reaction was limited to GI symptoms or rigors or fatigue or headache or a non-urticarial rash, itching or flushing. And then it was also considered low risk if they had hives, but those were more than 5 years ago. And so if they were low risk, they were randomized to penicillin skin testing followed by an oral challenge, or no skin testing and a graded oral challenge with amoxicillin, where they received a 25 milligram dose and then 250 milligrams of amoxicillin later. And importantly, 94% of people in the skin test arm and 91% in the graded oral challenge arm were deemed not allergic and could receive standard therapy for syphilis or gonorrhea if they were receiving ceftriaxone for that and had a history of a penicillin allergy. And this is one of several studies which highlight this strategy of doing graded oral challenges of people who meet certain criteria in terms of their penicillin allergy. And this is also now being adopted in many settings, including in obstetric practices when people are being screened for group B strep and then potentially requiring treatment for that in pregnancy. Okay. If you think of questions as we move along, please put them in the Q&A, and then we'll certainly have plenty of time to answer those as we move towards the end of our presentation. We have a few more cases, though. Our next patient is a 51-year-old man who is on PrEP with cabotegravir. That's one of the long-acting injections that's available for PrEP. And he presents to the clinic with 3 days of rectal pain, mucus discharge, tenesmus, and sweats. His vital signs are normal. A perirectal exam shows no lesions, and he's unable to tolerate anoscopy. Tests are sent for gonorrhea, chlamydia, syphilis, and HIV, and he begins treatment with ceftriaxone IM once and doxycycline 100 milligrams by mouth twice daily. That's the standard regimen for proctitis, which is the clinical syndrome that the clinician thinks this patient has. That afternoon, though, he has a fever to 102 degrees, malaise, headache, and diaphoresis. He presents to urgent care, where he appears well aside from fever. At that time, most of the lab tests from his visit earlier in the day are not back, but his treponemal antibody is, and it's newly positive. However, the confirmatory test is still pending. And so my question for you, remember, this is a patient who presented with proctitis, who received antibiotics and now has fever, malaise, headache, and diaphoresis. My question for you is, what is the next best step in management? And we can go ahead and watch the poll. Is this to send the patient to the hospital? Is it to obtain an urgent CT of the abdomen pelvis with contrast? Is it to continue the doxycycline? He received the ceftriaxone already, but he's on the doxycycline. Is it to stop all of his antimicrobials, or is it to do something else? We'll give you a few more seconds to answer. All right. So I hope you're able to see the results. The most popular responses were A, B, and C, with the largest group choosing C. Um, Excellent. So C is what I would do as well. I think this patient has a Jerish-Herxheimer reaction. This was first described in 1895 by a dermatologist, and I mention that only to indicate that this reaction can occur with non-penicillin treatments of syphilis, because of course penicillin did not exist as a drug in 1895. This occurs with syphilis and with other spirochetal infections. And despite the fact that we've known about this reaction for more than 100 years, we actually have some very recent data about it from a randomized trial of 1 versus 3 weeks of treatment for early syphilis with benzathine penicillin. And we've learned that the Jerish-Herxheimer reaction occurs in a quarter of people with early syphilis who are treated with penicillin. The median time to onset is 5 hours, and the median duration is 13 hours. So this tends to be a fairly short-lived reaction. And the symptoms can include fever and flushing. They can include arthralgias and myalgias. If the patient had a rash to begin with, that can worsen, say if they had secondary syphilis. They may have tachycardia and palpitations, nausea, headache, and dizziness. And some risk factors for having the Jerish-Herxheimer reaction are having secondary syphilis. Those individuals tend to be spirochetemic and have a high organism burden. And so in the setting of treatment, they may have a more robust inflammatory response. It is less common in people who have a history of syphilis, and that's probably because they have some partial immunity and potentially a lower organism burden to begin with. And it's also less common among people with HIV, and that may be related to immune function. And so if you are treating someone for early syphilis, I always counsel people about the possibility of a Jerish-Herxheimer reaction. And if they call back and they have a fever or flushing or other symptoms like that, then this would be at the top of my differential diagnosis. Of course, I would think about other possibilities as well. But if these symptoms are mild and abate over the course of hours, it is likely this reaction. Now, this case also highlights that syphilis can cause proctitis. When a patient presents with proctitis and we think it's sexually transmitted, potential causes include gonorrhea. They include chlamydia, including the LGV or lymphogranuloma venereum variant. It includes syphilis. It also includes herpes simplex virus. And more recently, we also need to be concerned about Mpox. The standard therapy for proctitis includes ceftriaxone and gonorrhea. Those would, ceftriaxone and doxycycline, that would treat the gonorrhea, the chlamydia. It would also provide some initial therapy against syphilis. And then if ulcers are present, we tend to be concerned about HSV and Mpox. And so we would test for those entities and then also include empiric valacyclovir or acyclovir for the possibility of HSV while we're waiting for the test results. What I'm showing you here on this table is a list of presenting symptoms in people who were ultimately deemed to have syphilitic proctitis with anal pain and tenesmus and mucus discharge and diarrhea and fever, all being potential presenting symptoms. I would note that rash is not very common. And so while it is possible to find a chancre or other lesions of syphilis in this setting, they're not commonly observed. And so you do need to kind of maintain suspicion for this diagnosis. People in general should have positive serologic testing for syphilis if it is the cause of proctitis. Before we leave the topic of syphilis, I want to make a few points about syphilis management. One is that it's crucial to check an RPR on the day of treatment even if only a few days have elapsed since the diagnosis. One common scenario is someone comes in for STI screening, their syphilis test returns positive, and they're coming back some days later for treatment. But even if only a few days have elapsed, their RPR titer could have changed significantly. And this is especially true in early syphilis. So it's really important to repeat that titer again at the time you treat them, because that titer is what you're going to compare to look for a fourfold decline in the future with their syphilis treatment. Remember that for post-treatment monitoring, where you're looking for a full fourfold decline in titer, you can allow a full year for that to occur after treatment of early syphilis and 2 years after latent syphilis. It's also important to ask all patients with a new diagnosis of syphilis about ocular, otic, and neurologic symptoms, because those would require additional evaluation and potentially treatment for neurosyphilis with intravenous penicillin. And then finally, if there is a clinical concern for primary syphilis, so say someone comes in with a genital chancre, do not use serologic testing to exclude the diagnosis. 30% of people who have a chancre are seronegative because they haven't yet mounted that serologic response, even though they have syphilis. And so if someone comes in with a chancre, we treat them. We do send off the serologic testing, but we don't wait to see what it shows. And then if it's negative, not treat that individual. Finally, I want to emphasize that you can use your clinical judgment to stage syphilis. If someone, say, comes in with a rash that's compatible with syphilis and has a high RPR, 1 to 256, for example, that is secondary syphilis, even if they have no prior um, uh, RPRs or trypanosome antibodies on record and you're unsure of the time of acquisition. So really, you can kind of use your clinical judgment based on the history and the exam and the information from serologic testing to come up with what you think is most likely that patient's stage, and then treat them and follow them appropriately. Our next patient is a 37-year-old woman who presents with bacterial vaginosis. This is diagnosed based on the AMSL criteria. And as a refresher, those include discharge, clue cells on a wet mount, vaginal fluid pH greater than 4.5, and a fishy odor that was not present in this case. This is her second episode in the past year. The prior episode was treated with metronidazole gel. She has one male sexual partner, and you prescribe oral metronidazole for 7 days for her. And so my question is, what else would you do for this patient? And we can go ahead and launch the poll. Would you recommend that her male partner present for evaluation and treatment? Would you prescribe oral metronidazole and topical clindamycin for him, both for 7 days? Or would you do something else? Please go ahead and select your responses. All right. Go ahead and end the poll. 52% of you chose A, that's what I would do. And then the next most popular response was B. Great. So I use this case to highlight a recent study published in the New England Journal about male partner treatment for recurrent bacterial vaginosis. There have been several studies of this in the past which did not show a benefit, but this randomized trial did. And in the group of women whose male partners were treated with oral metronidazole and topical clindamycin, there was a reduced likelihood of recurrent bacterial vaginosis. Importantly, the risk of recurrence was not eliminated. Many people, around a third, still had recurrence in the course of this trial, but that likelihood was reduced. One thing I would note, though, is that it is thought that circumcision status may matter in the context of recurrent bacterial vaginosis. 80% of the men in this study were uncircumcised, and we know that the incidence of BV is higher in women whose male partners are uncircumcised, but more than 70% of American men are circumcised. So we don't know if the same effect would be seen in a population of men in which many or the majority are circumcised. I would not use that as a reason not to provide this treatment if there is a male partner who is willing to take it. but I think it's an area where further research is needed. I would note, going back to our answer options, that B really refers to a context of expedited partner therapy that is sanctioned for chlamydia and in some cases gonorrhea in many places in the US. But to my knowledge, there is no evidence about or kind of regulatory approval of expedited partner therapy for bacterial vaginosis. And so I don't think that that would be an option in most cases. And so if we want to treat the male partner, we would need to have that person come in and have their own evaluation and be prescribed those medications directly. Okay. Our last patient is a 32-year-old man who has sex with men who's taking emtricitabine, tenofovir, disoproxil fumarate for PrEP. That's one of the oral PrEP drugs. And he presents for a routine follow-up visit. He's doing well and has no symptoms. At his last visit 3 months ago, he was diagnosed with early latent syphilis and was treated with IM benzathine penicillin. And so my question for you, and we can go ahead and launch the poll, is would you recommend doxycycline post-exposure prophylaxis for him? Yes, no, or I don't know. We'll give you a few more seconds to answer. Okay. So 56% of you said yes, and then 30% said that they were not sure. Great. So let's talk about doxycycline post-exposure prophylaxis. This is an evidence-based intervention that is now recommended by CDC. I'm showing you here the 4 major randomized trials of doxycycline post-exposure prophylaxis. The top 3 were performed primarily among MSM, and all found a benefit in reducing chlamydia and syphilis, and in some cases, gonorrhea. The study at the bottom, the DPEP study, was performed in Kenya and enrolled cisgender women who were taking PrEP for HIV. They found in that study that doxypep did not reduce the likelihood of STIs. However, based on drug level analysis in hair, most people in the study did not take doxycycline. And so it's thought that that study may have not shown a benefit because adherence to the intervention was low. When I talk about doxypep, I'm talking about taking a single dose of doxycycline at 200 milligrams. In most cases, that's 2 pills, once within 72 hours after condomless sex. Here are some data from our own clinic in which doxypep prescribing has increased rapidly. You can see this kind of big upswing in the number of starts of doxypep beginning back in 2023. And similar to other settings around the country, we have seen reductions in the real world in STIs. There have been declines in chlamydia and syphilis, but not declines in gonorrhea. And that finding has been fairly stable around the country with these benefits for chlamydia and syphilis and not gonorrhea. That is because gonorrhea at baseline has more doxycycline resistance than certainly chlamydia or syphilis, in which doxycycline resistance is really not described. What are the potential harms of doxypep? Well, there are certainly the known medication side effects, but of course, doxycycline has been around for a long time. So we have, it has a well-known side effect profile. We know that people can have gastrointestinal upset. Most seriously, people can have piloesophagitis. That's shown there on the right-hand side of the slide, but that is not common. And sun sensitivity can also occur. I'd note that in studies of doxypep that serious adverse events were not more common with this intervention. However, I think of greater concern would be antimicrobial resistance with doxypep and effects on the microbiome. And then theoretically, there has been concern about impaired diagnosis of syphilis. Perhaps doxypep would just blunt or delay the serologic response to syphilis, but not fully prevent that infection. That's been a theoretical concern, but we as of yet not seen any evidence that that's the case. In terms of antimicrobial resistance, I would say that the picture we have is a mixed one. And that is that, doxypep in some studies does reduce, say, gonorrhea, and does reduce Staph aureus colonization, although that latter effect is not why we use it. But when those organisms are present in the setting of doxypep, they tend to be more likely to be doxycycline resistant, which is as expected because we know we're exerting selective pressure with this antibiotic. What about impacts on the microbiome, the organisms that live on and in us normally? Um, well, we know that microbiome perturbations are associated with obesity and other chronic diseases, but really how to counsel patients about these changes is uncertain. And one thing I want to point out is that if you have patients who have a high likelihood for STIs, then really the choice is not doxypep or no antibiotics. It's doxypep versus antibiotics for the infections that are otherwise being prevented. And so, how this all shakes out, I think, is still under investigation. Of course, one of the most common microbiome perturbations that we think about is C. diff. And doxycycline is fortunately one of the least C. diff promoting antibacterials, although C. diff can still occur with any antimicrobial. So my question for you now is that if this patient were a woman who had had early syphilis a few months ago and is on PrEP for HIV, would you recommend doxypep for her? We can go ahead and launch that poll. Would you say yes, no, or I don't know? All right, go ahead and share the results. So we're about evenly split between yes and I don't know, and then a smaller group is saying no. Well, as a reminder, doxypep did not prevent STIs among cisgender women in Kenya. Again, we think that's because of low adherence to doxycycline. Pharmacokinetically, we suspect it would work, but in that randomized trial, it did not. That being said, we do have some non-randomized data suggesting a benefit. This is a study of doxycycline taken daily for STI prevention among female sex workers in Japan. And you can see, for example, a decline in syphilis diagnoses in this cohort, and also an apparent decline in gonorrhea and in chlamydia. So I don't think that prescribing doxypep to a woman is wrong, but I think it would involve shared decision making and talking about what is known and not known about this intervention. CDC has released guidelines on doxypep, and I've put those in the box there. They do recommend that that providers counsel gay, bisexual, and other MSM and transgender women with a history of STIs in the past year about this intervention. And when we do this, some key messages that we include are that doxypep is not an FDA-approved intervention, but it is an evidence-based one. We talk about the expected benefits, adverse events, including side effects, the impacts on the microbiome, and antimicrobial resistance. And then we also counsel patients to return every 3 to 6 months for STI screening. Now, there are a number of implementation questions that have come up with doxypep. And I'm showing you some answers here based on the doxypep trial. That was one of those large randomized trials of this intervention. With 60 pills of doxycycline being enough for 3 months for most people. I think it's really uncertain how STI screening should be adapted in these patients. The CDC does recommend screening every 3 to 6 months. And in general, other laboratory monitoring for doxypep is not required because other organ toxicity is not expected. So in summary for all of this, I think you can consider minocycline plus or minus metronidazole for treatment for refractory M. genitalium. Most treatment failures for gonorrhea are reinfections, and they can be treated again with first-line therapy. Doxycycline and ceftriaxone are the most evidence-based alternatives to penicillin for syphilis treatment for non-pregnant people. Penicillin is still considered the only treatment for people who are pregnant. Male partner treatment reduces the likelihood of recurrent bacterial vaginosis in women, and doxypep prevents chlamydia and syphilis, and to a lesser extent, gonorrhea. In terms of next best steps, I would alert your public health colleagues if you suspect ceftriaxone non-susceptible gonorrhea, and try to obtain a culture from that person for antimicrobial susceptibility testing. I counsel all patients with early syphilis about the possibility of the Jarisch-Herxheimer reaction. It's important to consider syphilis in the diagnosis of proctitis. and then also consider male partner treatment for women with bacterial vaginosis, and then offer doxypep to people who may benefit. So now I'm happy to take any questions or comments that you have.
Dr. Orr, thank you so much for this uh, 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 timely and well-informed update for us. Truly appreciate it. First question relates to the fact that you alluded to most pharyngeal gonorrhea being asymptomatic. What are the times we should be thinking about it and checking for it?
Great question. So currently, testing that site is recommended for MSM. It's also recommended for people who have had sexual behavior that might have exposed the pharynx through shared decision making. That would be with women, heterosexual men, transgender and gender diverse people. And then I think the other scenario is if someone is coming to you reporting exposure to gonorrhea. They were informed by a sex partner that that partner tested positive for gonorrhea, and they tell you that they use their mouth with for sex with that person. Then you would think about testing the throat. And really, we even though it's typically asymptomatic and does eventually go away on its own, we care about infection at that site because we think it is important for transmission, and also because we think it may also be important in terms of driving some antimicrobial resistance in gonorrhea. There's a lot of bacteria there, including some commensal Neisseria species, and they can exchange genes with Neisseria gonorrhea.
Thank you. Next question relates to evaluating the male partner for BV, because you alluded to bringing that male partner in, not just for treatment, but for evaluation. And are we in fact doing any evaluation at that visit?
No, so we're not, the male partner, we're not looking for symptoms in the male partner. And I apologize if I misspoke, but the purpose of having a clinical interaction with the man is to, talk about the treatment, ensure there are no allergies, counsel about the medications and prescribe them. But we're not, looking for any clinical signs or symptoms in the man that would, tell us that this is or is not, a good approach to take. And so, I think, for example, if a male partner is willing, that could be a telemedicine visit. It wouldn't need to be an in-person evaluation.
Thank you for that clarification. Just want to encourage, in case others may have questions, please put them into the Q&A. In the interim, one other question relates to something that certainly happened in my setting, which is we've lost the capacity to be able to do wet mount testing in the clinic, being replaced by a laboratory, which in some of our settings has a fairly quick turnaround, but in others does not. And how do you handle that?
Yeah, that's really unfortunate. And I think that they're going to have to pry the microscope out of my hands eventually, because we really don't want to get rid of it. I think it's very useful for clinical care. I don't know that I have a great solution to that scenario in all cases. I mean, I think if to the extent that you can, advocating to improve the turnaround time, or also, seeing if there are other point of care tests, because there are a lot that are being developed right now that you might be allowed to deploy in your setting. There are, antigen or PCR based tests that are now being deployed at the point of care for many STIs and clinical syndromes, and that might be one way to try to kind of bring back rapid diagnosis just in a different way.
Question about how you go about addressing STI screening in patients who may have some degree of mental impairment, but nonetheless are still sexually active.
Yeah, I mean, I think I would like to know a little bit more about the scenario. I think there are, lots of possible, mental impairments we could think of, and I think depending on the impairment, you'd also want to ensure that this was, consensual sexual activity. But I think I would approach screening this in the same way as I would with anyone else. Indicate if they're sexually active, then we do screen in certain scenarios, and to offer that screening as I would other types of health screenings, cholesterol, um, diabetes, and so forth.
Very good. And I think with that, we're coming up very close to the end of our time. So we'll go ahead and end this session here, Dr. Ard. This has been really helpful super informative, quite relevant for us in primary care. Thank you very much for your time here. And with that, we'll conclude this session and remind folks that we'll be reconvening in 15 minutes. Thank you.
Thank you, everyone.